So it is that balance, but I think that's what keeps me up at night. I mean, the 12 month of survival is not the survival we are looking for. We got to get it to a point wherein it is a chronic disease. And that's the goal. I mean, diabetes 50 years ago wasn't a chronic disease, but now it is. So that's what keeps me up at night, but that's what I'm excited about.
Dr. Madappa Kundranda, who is an oncologist at Banner MD Anderson here in Phoenix. We used to work together at Cancer Treatment Centers of America in the past, so I got to know Dr. Kundranda really well, and I thought you'd be a great person to interview for this show. So thanks for being here. Let's start talking about your background. So where are you from? Where did you train, etc.?
Thank you, Gaurav, for having me here. It's a pleasure to be here and chat with you this afternoon. I started my medical school in India, finished my bachelor's there, and then moved to Nashville, Tennessee, wherein I got my PhD in cancer biology at Meharry Medical College, and then moved up to the Cleveland Clinic Health System to finish my residency in internal medicine, and then to the Mayo Clinic to finish up my fellowship in medical oncology.
And then you decided to stay in Phoenix to practice.
That is correct.
Right. And so what kind of patients do you treat day to day?
So I am a medical oncologist, and I mainly treat the cancers of the GI tract.
Okay.
So it could be the lower esophageal, the gastric, colorectal, pancreatic, and hepatobiliary tumors.
Okay. And is there one specific out of those? Is there one that you see, one type of patient you see more than the others, or?
Just by virtue of numbers itself, we have a higher patient population with colorectal patients.
Yeah.
So yeah, I do tend to see a lot more colorectal patients in my clinic, have several clinical trials.
Yeah.
But my research interest, if there's one research interest in the context of it, is mainly in the context of pancreatic and liver cancers.
Okay. So, we can talk about colon cancer for a little bit. So, when I was in medical school and back in 1999 or 2000, someone with metastatic colon cancer, their life expectancy was about, 12 months or so.
Correct.
Right. And then 10 years prior to that, like back in 1990, it was like 8 months. Okay.
Correct.
So in that decade, you'd had a kind of a 4-month gain, right? And then today, it's way higher, right? So 15 years later, it's somewhere closer to probably 2 to 3 years.
Correct.
Right. And so what's been the progress? Why are people living longer with metastatic colon cancer? And when I say metastatic, it means people who have cancer of their colon, but it's spread to other parts of the body.
Correct.
Right. So what's been the gain?
So again, when you were in med school, when you started, we had 5-FU leucovorin.
So those are the two main drugs.
Drugs that we had. One is a vitamin that helps in helping the chemotherapy not to get broken down.
Yeah.
And so in essence, we had one chemotherapy drug.
Yeah.
Since then, we've had multiple combinations. We've had multiple permutations and combinations of drugs. We've had newer drugs, all of which have pushed the bar from the 6 to 8 months to about 36 months.
Sure.
But I think equally important is the fact that in that period of time, supportive care has become an integral part of cancer care.
Okay, so what is supportive care?
So supportive care is, again, when a patient comes in, it's not just about chemotherapy, and more chemotherapy. It's worrying about a patient's nutrition, having my nutritionist work with the patient in terms of weight loss and the like, being more aggressive about managing for symptoms for our toxicities of the chemotherapy, such as the neuropathy, the fatigue.
Sure.
Because it's not that patients don't tolerate it. Patients do have a level of toxicities that they can tolerate. If you can get aggressive in terms of managing those toxicities, you can get them more therapy. You can get them more lines of therapy, hence causing them to live longer. So it's a combination of newer drugs and supportive care and better supportive care that's actually helped in pushing the bar.
Okay, so you're saying, just to summarize a little bit, you can be a lot more aggressive with a chemo, which has somewhat toxic side effects, if you kind of tune up the patient with nutrition, with monitoring the side effects, with just giving them more energy, basically.
Correct. Yeah, being more aggressive in terms of monitoring the side effects
Okay.
and yeah, intervening when you
Right.
need to.
So the typical, colon cancer patient, they typically start off with what is the first line of chemo?
So the first line of chemo, again, it could be this combination of two cytotoxic chemotherapy drugs. One is usually the 5-FU,
Yeah.
which is the backbone, and you can use a platinum-based oxaliplatin,
Right.
or you can use irinotecan-based.
Right. So
And-
so the acronym the patients are going to hear
Is FOLFOX,
FOL, FOX,
FOX, or FOLFIRI,
FOL, FIRI. Okay.
in addition to bevacizumab, which is the anti-angiogenic,
Right.
or again an anti-EGFR, such as cetuximab or panitumumab.
Okay. So you got, on one hand, you got FOLFOX, FOLFIRI, and maybe some other
A few of the
combination.
targeted therapies based on their molecular profile.
Right, in combination with these biologic or targeted chemotherapy agents, right?
Correct.
And so what happens if a patient progresses on, let's say, one certain combination?
Then you just switch them to the other. So you
Okay.
have your first line and your second line, so to
Right.
speak.
Okay. And then what kind of adjunctive kind of treatments can they get? Let's say if they have, metastases elsewhere in the body, or...
So that's an important question, because when you look at patients with colorectal cancer, what we realized is, for the most part, most of the metastases, the initial site of metastases is the liver.
Okay, because the blood flow from the colon drains into the liver first.
Correct.
Right.
So hence, most of the patients who's present with stage 4 metastatic disease
Yeah.
tend to have some amount of liver involvement.
Okay.
Now, what we realized in the last several years is the more aggressive you are with liver-directed therapy,
Yeah.
aka either if you can surgically resect it,
Sure.
or if you cannot surgically resect it, if you can use other techniques such as radioembolization or chemoembolization,
Okay.
or if you can even use SBRT, which is a form of radiation,
Sure.
if you get better liver control, patients tend to live longer.
Okay.
And so that is an adjunct therapy, and there's a recent trial that actually demonstrated that you can use it safely in combination with chemotherapy to use this radioembolization in patients who have liver
Sure.
predominant disease.
And then, me and you worked on a little small research project looking at how the blood flow to these liver tumors affects the efficacy, or how well the Y90 radioembolization works. So that was a pretty cool project. So
Yeah.
you also see pancreatic cancer patients, right?
Yes,
So
that's right.
those are some of the most aggressive kind of cancers that we know very little about, right, as far as how to treat and how to manage those. Would you agree with that statement, or?
I would probably not. I agree to a certain extent that yes, it is one of the most aggressive tumors.
Sure.
Do we know how to treat them? I think we're getting better at it.
Okay.
Are we there yet? Absolutely not.
Okay.
By no means.
So what makes pancreatic cancer so hard to treat?
So there's several theories as to why pancreatic cancer is a difficult cancer to treat. One is by the time you diagnose patients with pancreatic cancer, almost 80% of them have stage 4 disease.
Okay.
So that's one
So
problem.
we only find out about it after it's spread
Correct.
outside the pancreas to other parts of the body.
In a majority of the cases.
Yeah.
But unlike colon cancer, wherein you can prevent colon cancer with routine colonoscopies and the
Sure.
like, there are no screening tests for pancreatic cancer.
Okay, so we don't have a way to just go to the doctor every once in a while
Correct.
and see if you have pancreatic cancer. There's no test that works like that.
Correct.
Yet.
Yet.
Okay.
So, and the third thing is, until recently, we've had very limited therapies, which was one chemotherapy drug called gemcitabine,
Sure.
which was the FDA-approved drug until about 2011.
Yeah.
And so for 15 years, we didn't have anything other than gemcitabine, which in a sense improved the survival of patients with pancreatic cancer to up to about 6 months.
Right.
So those are the main reasons and the last reason is also because I think to a certain extent it was a cancer wherein in the community, if somebody saw a patient with pancreatic cancer, it was almost almost always a death sentence, so to speak.
Yeah. And just to clarify, right now we're talking about pancreatic adenocarcinoma.
Correct.
Right? Not the neuroendocrine tumors, right?
Correct, because that's a completely different
animal
by itself. Correct.
Okay. And so what is on the horizon, or what's the future of adenocarcinoma treatment of the pancreas?
Correct. So with the pancreatic adenocarcinomas, one of the things that changed was the French investigators looked at a combination of using 3 chemotherapy drugs that helped in the context of improving the survival to close to about a year in patients with stage 4 disease.
Yeah.
That was a huge change because until then the median survival was about 6 months.
Yeah.
This kind of pushed the bar to almost a year. But again, this is not one of those things where that is not the end. However, what it did was it actually opened the door up to looking at pancreatic cancer having other options. One of the other trials that helped in pushing the bar in patients with pancreatic cancer actually came out of the valley here in Phoenix, which was a combination of gemcitabine, which is the traditional chemotherapy drug, and this drug called Abraxane, which is albumin-linked paclitaxel, which is a chemotherapy.
Okay.
So just using the combination of gemcitabine with Abraxane helped in improving the survival.
Yeah.
So now we've gone from just having one chemotherapy drug that had a survival of about 3 to 6 months to having 2 good therapies that you could build on.
You could build on. So it's a first step kind of to hopefully increasing the time to progression and the survival of these patients, right?
Yeah.
So when we used to work together at CTCA, you used to see a lot of these pancreatic cancer patients, right?
Right.
And so most of these patients, like we were saying, there's not a lot of great options.
Right.
And you told me a story about how I forgot if it was your wife or someone asked you, like, how do you do it? How do you see these patients day in, day out?
Yeah.
And how do you deal with that? So talk about the answer you gave for that.
So it's a journey.
Yeah.
Right? So there are 2 components to this. So a long time ago, one of my mentors actually told me that you can either cure a patient, or you can heal a patient.
Yeah.
All right? Unfortunately, in medical oncology, in GI oncology, there are not a whole lot of quote unquote the cures that you have.
Yeah.
But the key thing is to help the patient and to heal the patient through this journey.
Sure.
So that is challenging, right?
Yeah.
Because you have patients who are young, you get emotionally attached to the patient and the family.
Yeah.
You're trying to do everything to make sure that they maintain a good quality of life while you're improving their survival. And in a majority of the cases, unfortunately, they succumb to it.
Yeah.
So it is that balance, but I think that's what keeps me up at night. I mean, the 12-month of survival is not the survival we are looking for.
Yeah.
We got to get it to a point wherein it is a chronic disease.
Right.
And that's the goal. I mean, diabetes 50 years ago wasn't a chronic disease.
Yeah.
But now it is.
Right.
So that's what keeps me up at night, but that's what I'm excited about.
Yeah.
But the reality of it is in 2015 or 2016, we are not there yet.
Yeah.
But we're seeing a lot of new therapies emerging, such as the immunotherapy trials, which have that promise to basically have patients on therapy live for a much longer period of time without any evidence of the disease coming back.
Sure. There's like an average outcome.
Correct.
But that doesn't mean this patient is one of the average.
Exactly.
Right?
Exactly. Right. So that's when you just club them into being a number, right?
Yeah.
So we are not as good at predicting which one of these patients are going to be getting that quote unquote that average outcome, as you mentioned, to the ones who are not going to be, right?
Yeah.
So we are still in the process. So for me, numbers help in putting together the big picture.
Yeah.
But what predicts the patient's prognosis, the patient who's sitting in front of me with stage 4 disease, are 2 things. One is tolerance, and the second one is response to therapy.
Yeah.
I can have the best therapy in the world for the patient, but if the patient's not tolerating it, it's not the best therapy for the patient.
You mean if they have a lot of side effects?
Correct.
Okay.
And that's where the supportive component part of it becomes integral. So once you know a patient's tolerating therapy,
Yeah.
That's when you start looking for the response.
Right. So a patient comes to you with pancreatic cancer, right? And they say, you got to help me.
Right.
What do you tell them?
So again, we're talking about patients with stage 4
Yes.
adenocarcinoma of the pancreas, correct?
Meaning they don't have any surgical options, you know.
Correct.
Right.
So the key thing is, it's in most of these patients when you're giving chemotherapy, it's to prolong life, but to also maintain the quality of life.
Okay.
So it's the quantity and the quality.
Right.
And it's this fine balance as a medical oncologist that you're trying to do between increasing their quantity, but also making sure that the quality of life is maintained during treatment.
Right.
So this is, I think, integral when you're looking at any patient with stage 4 disease that's not curable, wherein you're trying to get this disease under control for a period of time. Because truly, you improve the survival for 6 months.
Yeah.
But if the patient's in bed for 5 out of the 6 months, how have you really helped the patient, right?
Yeah.
And this is a candid conversation I have with my patients, because there's not a single patient in all my years that's ever come to me and said, hey, I want to live for 10 years, but I'm fine with staying in bed for 9 out of those 10 years, right?
Yeah.
And the second question is, what is the next immediate goal that the patient has? It could be a birthday, a grandchild's birthday, it could be the birth of a child, it could be the graduation of somebody. So these are these things that you look for and you say, this is the first thing that we're going to shoot for.
So these are like life's milestones.
Exactly.
So you patients know that they're going to succumb to the disease.
Right.
But they probably all have some sort of life milestone they want to reach before then.
Correct.
So do you have any examples of certain
Yeah,
patients?
so even before we get to the question of an example there, right?
Yeah.
So the other question is also, when you have patients who have had this, yes, it's trying to get to that first life, that milestone, right?
Yeah.
But nevertheless, there's hope and there's reality.
Yeah.
You can never really lose hope,
Yeah.
but you need to still balance it with reality,
Sure.
right? Because the hope is, yes, we'll get you to the first milestone, we'll get you to the 20th milestone. That's the component of hope.
Yeah.
But the reality is you're dealing with stage 4 disease,
Yeah.
which in 2016 is quote unquote incurable, right? So it's that balance. Now, one of the things that still that is touching is, there's a patient who came to me, and this patient had pancreatic cancer, and was told that he has 3 months to live and to get his affairs in order. So the guy came to me with his wife, and he was a cop who had served the community for the last 40 years, and he said, "Doc, I'm not ready to die." And I said, "I agree with you. I mean, but if I had any way of predicting anything or controlling it, it's the guy up there who's calling the shots, right?"
Yeah.
So we started talking about what he wanted to achieve for the next 6 months. What was his immediate goal? So he said, "You know what? My daughter is pregnant, and and she's to deliver my granddaughter in the next 6 months. I want to hold my granddaughter before I pass." So I said, "Okay, fine. That's a goal. Let's work towards that goal." And we got him to the granddaughter's, not just to the birth, we got him to the granddaughter's first birthday.
Wow.
And basically, and I think it was 6 months after that, unfortunately, he passed away.
Yeah.
But even till date, the wife is just so grateful that he lived to see all of this, because that was one of the most important things that they wanted to achieve at that point in time.
I think I think most patients who get diagnosed with something like this, they're realistic about what it means, but that's all they really want. They want oncologists who kind of will maximize their quantity of life, their quality of life, and help them get as far as they want along these milestones of life.
Right.
So the medical oncologists. So. They are kind of the center of the cancer treatment, right? So you have surgical oncologists, you have radiation oncologists, and then you have people like me, interventional radiologists, you have gastroenterology, GI doctors, nutritionists, and so forth. But the medical oncologist is kind of the leading the care of the patient, right?
Correct. You're like the quarterback there.
You're like
Correct.
the quarterback, and so you get to see a lot of these patients. They're kind of putting their faith in your hands, right? So that's got to be really rewarding for you.
It's rewarding, but you got to realize with the potential rewards, there's a lot of responsibility that comes with that. So
Yeah.
you cannot take that lightly. And I think the example that I give is when a patient walks in,
Yeah.
right? Say if it's a female patient with breast cancer, you've never seen the patient before. The patient sees you in clinic as a medical oncologist, as a breast oncologist. You have her placing her trust in you,
Yeah.
but it's also with her modesty and all of that, she's letting you examine her. I think that's a huge responsibility that I think as physicians, as a medical oncologist, we need to just take that very seriously.
Mm-hmm.
And I think most of us do. Because with that kind of responsibility, you do not have a choice but
Yeah.
to actually give you each and every patient each and every ounce of your thing
Yeah.
to help them live the longest time possible and maintain their quality of life.
Right. And one of the reasons I wanted to interview you is, we've had a lot of patients in common, and I'm always impressed with your outcomes. That I thought there were patients that I had seen, as one of these ancillary doctors who, should not have been living at that time, and you had gotten them into various clinical trials or et cetera, and they're still enjoying their life. So let's switch a little bit, the topic a little bit. So, there's a huge buzz in the healthcare community in general about immunotherapy, right? So talk. What is immunotherapy? And let's just start with that right now.
All right. So, yes, that's kind of one of the hottest topics in cancer therapies right now, right?
And even all of healthcare.
Exactly, in healthcare. So, when you think about immunotherapy per se, it's been there for the longest time with the Cooley's vaccine, right? With William Cooley at Memorial and all of that. So, we've had that wherein what he did, and he was a physician at the turn of the century who ended up injecting patients with the Cooley's vaccine, as he called it.
Okay.
Which in essence what it did was you would infect the patient with an infectious disease.
Okay.
The goal is that your body's immune system would start killing not just the infection but the cancer as well.
Yeah.
So you ramp up the immune system to kill the cancer. Unfortunately, he had some initial success, but the thing was a lot of his patients succumbed to the infection.
Okay.
And so that was kind of canned at that point in time. Over the period of time since the 50s and the 60s, with the interleukins and all of that, we saw that there was a trend towards improving the immune system, wherein you could artificially get your body's innate system to basically fight these cancers. One of the key things was the fact that with immunotherapy, when it was successful, we've always had an instance wherein patients would live longer without any disease. And so you had what we call a durable response, which was the key thing.
Yeah.
It was only off late in the last 5 to 7 years wherein we've looked at a different way of looking at it. So why is it that the body's immune system doesn't recognize the cancer cells and kill it at the get-go?
Right.
Right?
So it doesn't recognize it as as something bad.
Correct.
Okay.
And why doesn't it kill it, right? Because you have an immune system that you have the immune surveillance,
Yeah.
the body's innate immune surveillance. So the way the body's immune system works is when you have an infection, say for example, you have a checkpoint, meaning to say you can ramp up the immune system, but you do not attack your own body. So that's the check and balance that's there, so that with just a simple cold, your immune system doesn't get ramped up to a point where it starts attacking your normal body and you basically succumb not to the cold, but basically to a hyper-activated immune system.
Sure.
With cancer cells, tend to use that. That is the Achilles heel that's basically there, wherein the cancer cells tend to use that the mode to actually suppress the immune system.
Yeah.
And then it evades the body's surveillance.
So the cancer has a checkpoint where it tricks the body into not attacking it.
Into not recognizing it, correct, and hence not attacking it.
Right.
So the newer drugs that are there, the checkpoint inhibitors, the CTLA4 inhibitors and the like, what it's doing is it's taking the brake off that immune system so that the immune system can be ramped up and attack these cancer cells.
Yeah.
However, I mean, we're still very early. We've had some early successes with melanomas and all of those, which have been durable, which is great.
Okay.
However, the key thing is these drugs are not without side effects.
Yeah. And so the early cancers that have been studied with this are which ones?
Well, melanoma.
Melanoma, okay.
We've had success with renal cell carcinoma.
And these are all metastatic or no?
These are all metastatic.
So patients with metastatic melanoma, metastatic renal cell carcinoma.
And now we're seeing a lot more success in even colorectal cancer patients with a specific subset called microsatellite unstable high patients.
Okay.
You've had initial success in some of the squamous cell carcinomas, which are non-skin squamous cell carcinomas. We're starting to see quite a bit of that percolating into the GI cancers as well.
How about lung cancer?
Lung cancer is one of the huge initial successes that we had with melanoma, with renal cell, and with lung.
And when you use the word durable just now,
Okay.
why is that important?
Because usually with chemotherapies, whether it's cytotoxic chemotherapy, the traditional chemotherapy, or with targeted agents, one of the things that happens is over a period of time when you treat the patient with cancers, it's not just the toxicities.
Mm-hmm.
Patients stop responding and the disease gets worse.
Because the cancer cells mutate, or how does that
Correct.
work? Okay.
So that's a whole entire topic in terms of why these cancer cells, quote unquote, develop resistance.
Okay.
And there are a few theories as to why they do. One of the things is the fact that you could have a specific clone that's being killed by the specific therapy, and then it's the alternate clone
Yeah.
which is resistant to the current therapy that takes off because it's the path of least resistance.
Sure.
So, but nevertheless, in patients with immunotherapy, what we are seeing is not some of these patients that we've treated, even after 2 to 3 years, they're not having the disease come back.
Okay.
Do we understand that entirely? No, not at this point. But I think that's where the next step in the understanding of immunotherapy and how that really affects us is what is ongoing.
So the word durable means it lasts. The positive effect of the treatment lasts for
A long period
a lot
of time.
longer than with traditional chemotherapy.
Correct.
And is it true? I know a little bit about immunotherapy, but that the side effects are a little bit better tolerated
Right.
than traditional chemo?
Yes and no.
Okay.
Because again, with traditional chemotherapy, you expect a suppression of your blood count, right? So we get the patients and we monitor them closely. You end up having patients with nausea and vomiting. Some of these traditional side effects do not exist with immunotherapy. But most of the side effects that are present with immunotherapy is based on the fact that the immune system is ramped up. And so you have a lot of these inflammation, you have your colitis, you have your pneumonitis, a lot of the itis or the inflammation of these different organs that, you need to be cognizant of.
And is it just checkpoint inhibitors, or what other chemotherapy agents are there now? Or immunotherapy techniques?
Correct. So the previous ones before we had the checkpoint inhibitors were the CTLA4. That was the initial inhibitor pathway that we looked at.
Mm-hmm.
Then now we have the checkpoint inhibitors. Now we have the chimeric or the CAR therapy per se, And one of the things that I'm working on right now is looking at how you can reverse engineer the healthy T cells that could be injected from in a cancer patient, wherein we know in bone marrow transplant that you have the graft versus the leukemia effect, but you also have the graft versus the host effect. So the graft versus the leukemia effect means if I take your T cells or I take your cells and I inject it, or I take your tissue and I inject it in myself, my body is going to automatically reject it saying it's foreign. However, what's going to happen is the graft is also going to mount that response against the leukemia. All right? So that's the graft versus the leukemia effect. Now, the problem is when you have the graft versus, and we're talking about these allogeneic stem cell issues that we have in leukemia and lymphoma, you also have the graft versus the host. So the graft is going to mount a response against the host.
Yeah.
So what we are working on in colon cancer right now is looking at how we can engineer, or we actually have a product and we're going to be trying it out in early phase clinical trials very soon, looking at how you can take these cells, the immune cells from a healthy donor, reverse engineer it so that you don't have the graft versus the host, but you have the graft versus the tumor effect.
Yeah.
So that's something that's exciting. So those are the few things that's going on.
Okay. So immunotherapy is a big field. There's these checkpoint inhibitors that are kind of they're probably the most well-studied treatment right now. There's lots of other, though, therapies on the horizon which kind of encompass the same principle.
Yes, yeah, so it does. And checkpoint inhibitors, I wouldn't say have been extensively studied but it's the newest kid on the block.
Right.
And so we have a lot of trials with checkpoint inhibitors. We just need to wait and see how it pans out over a period of time.
Yeah.
But you have a lot of therapies in the horizon, including looking at other vaccines and checking to see how you can ramp up the immune system with a specific infection, such as a Listeria infection, which is what we have as well, and then using a vaccine to suppress basically the cancer.
Right. So in the overall treatment of cancers over many decades, how big is immunotherapy?
Right now, it seems to be one of the biggest things.
Okay.
However, given the fact that we've had a lot of these early successes in oncology, in the early 2000s when we spoke about targeted agents, we thought we would cure cancer in the next 5 to 10 years. Targeted agents have served their purpose, and we've realized we've gotten to a roadblock with that. So now we are looking at a different line of treating it. I think eventually the goal in cancer care is going to be sequential therapies. But the key thing is to make sure patients tolerate those therapies so that they can get subsequent therapies.
Right. And the big picture is to try to turn cancer into a chronic disease.
Exactly.
Right.
Exactly.
Just like diabetes, just like asthma, just like that, right?
Exactly.
All right. Well, that was a very interesting conversation, and thank you, Madhi, for being the first guest on my show. I think anyone in the community who knows someone or has one of these GI tract cancers, they do well to contact you. So thank you.
Absolutely. Thank you, Gaurav, for having me.
Sure.